he returned to our motherland with the motto of utilizing his knowledge and skills for the noble cause of service to humanity. Presently, he is working as a CEO of an NGO sector, JeevaRaksha, which is a model emergency department at the outskirts or rural area of the Mysuru. And under the RGHS JeevaRaksha project, he has conceptualized and set up a model emergency department at Vivekanand Memorial Hospital. And this NGO mainly works with the objective of enabling primary healthcare providers with effective and evidence-based skills to deal with emergencies, disasters, and also equipping tertiary trauma care centers to provide state-of-art emergency care. He is utilizing his all expertise in the field of training. Thousands of students he is training right now. And he was course director of ATLS, pre-hospital trauma life, this thing. And with all this expertise, he is training our faculty members as well as professional members as well as common citizens. His expertise in simulation and skill training and pre-hospital medicine and disaster management is creating a state-of-art setups in the Karnataka right now, but it is of course going to go globally. He is editor of multiple emergency care training modules. So here we have Dr. Ram Nair. I invite you, sir. And I'm sure that you will enjoy this session.
Hello, can you hear me? Is it that pose? So, we are all different, are we? There are specialists from different fields here. There are students. There is Dr. Thinker sitting in row number 5. So, all representing different specialties, different fields, and different years of experience. But when we go out, and some of you, your students will be applying for civil service exam, when they get into IAS or wherever they go, we always like the 2 letters in front of our name. The D and R never changes. Even if you're getting married or it's our last rites, it is never a Mr. or Shri or whatever, it's always the DR. Very proud of our 2 letters, right? Yes? Can't hear. Yes. Good. So we are awake. Right. So why are we so proud, and are we actually taking that 2 letters of pride out into the community and making a difference in the community? I'm talking outside the 4 walls of a medical college, outside your university campuses, outside the centralized AC, wonderfully decorated conference room. What are we doing outside? That's what this talk is about. Because 88% of emergencies in India are attended in primary health centers, community health centers, little private hospitals around the non-urban regions. So rural, suburban regions see 88% of emergency attendances. So the tertiary care hospitals, well-appointed medical colleges like AVMC, see a minuscule of our patients. Anyone knows how many people live after pre-hospital cardiac arrest in India? Sorry, I'll keep moving. If I give you 10,000 people who had cardiac arrest in our country, pre-hospital environment, how many live in our country? What's the statistics? So 1 to 10,000, how many live if they have a pre-hospital cardiac arrest? 10% is about 3% I have. I've got 10. Anybody else? 100%? 100 of 10,000. That would be 1%. Okay. Any other numbers? 1 to 2%. Not sounding very optimistic. 0. Almost close to the right answer. It is actually 0.01% is the answer, which is 1 in 10,000 or less. Okay. That is the survival rate out of a pre-hospital cardiac arrest in our country. Now when KK happens, or Puneet Rajkumar happens, or Mandira Bedi's husband happens, we all put our opinions out, we all tweet, we all put status messages. Shocking. Why didn't somebody do something at that point in time? There were 7,000 people attending KK's last concert. He started complaining 35 minutes before he was taken out. Sweating, feeling very, very short of breath, palpitations, feeling giddy. Sounds familiar? Yes, there was no chest pain, but everything else was there. He was sat down, he was given water, he was complaining about claustrophobia. He didn't want people standing around him. There were doctors and nurses in the crowd. But unfortunately, we as a crowd of specialists, healthcare professionals, don't know or don't do what's most appropriate at that point in time. If you book a railway ticket, Vande Bharat, somebody was mentioning today morning, 200 kilometers per hour or more, or an air ticket, we just keep that most proud 2 letters of our name, put it to the side, Mr. or Mrs. please. Don't bother me if something happens around me, because I am not confident what to do. You might be a surgical gastroenterologist. What if it is a child? We have got an obstetrician sitting behind us. What if it is a child? We've got a general medic sitting behind us. What if it is a trauma patient? Somebody's arm is broken and hanging with just a skin tag. What am I supposed to do? What's a death rate that is preventable from bleeding on our roads in India? Any idea? From extremity bleeding, from bleeding from arms and legs, how many extra people die on our roads? 40%, not a small number. 2 lakh something is the total recorded death numbers from last year's statistics. 40 more percentage in that number died because bleeding wasn't stopped. So what are we doing? What are you doing? What am I doing? And that is what JeevaRaksha is about. So shall I start? Everybody awake? Good to go? Excellent. Okay. So my name is Ram and I am an emergency physician, a little anesthetist, a little critical care guy, a surgeon, master of nothing, just a jack of multiple trades. I am currently associated with this organization. So this doesn't work. So that is JeevaRaksha Trust, which is a special purpose vehicle started by Rajiv Gandhi University of Health Sciences and Swami Vivekananda Youth Movement. Rajiv Gandhi University of Health Sciences, most of you might know, it's a state university in healthcare sciences, one of the largest in the world because of the number of institutions affiliated to it. And Swami Vivekananda Youth Movement, most of you might not know. It's a social development organization started by 12 interns from Mysuru Medical College in 1984. They went into the forest. After he married, our Rama was sent into the forest. These guys went voluntarily to the forest because they were conducting a blood donation camp in the name of Swami Vivekananda in Mysuru, and the district collector who had just visited the national forest regions came back and he was inaugurating the camp, and he basically said, what are you guys doing in the city? He had just visited what we call Hardis. Hardis are the little villages which was donated to the tribals who were kicked out of the forest in Bandipur and nearby reservation areas. Soon after, our Prime Minister Indira Gandhi decided that we are going to have national parks like the US. So all the inhabitants were moved out into the common world. These guys didn't know how to cook, how to clean, how to cultivate, how to do business. 2 types of population. One is Jaina Kuruba, who are collecting honey, selling it in the villages for food or cloth or whatever. The other is Kadu Kuruba. they were cultivating bamboo reeds, making stuff out of it, selling it out and getting whatever they needed to survive. Suddenly, out of this world, literally out of their own world, they were found in little villages, 10 cents per head, no housing, nothing, didn't know reading or writing, lots of locals took all their land. Ladies had to go into prostitution, unfortunately, to fend for their families. High number of infectious diseases, STIs, all sorts, and severe poverty, children completely malnourished, and people sitting in these hardis with no light in their eyes. They just wanted to die, but they didn't know how to. In their culture, that is also not acceptable, So, these people were visited by this district collector who came back and told his interns, what are you doing? You shouldn't be in a city doing blood donation camp. You should be out there. That's where the real need is. So that is Swami Vivekananda Youth Movement. They are an organization of solutions, not of comments or opinions. Hope you know the difference. Okay. So in 2013, large number of reported violence and abuse against doctors and nurses in the state of Karnataka. Can anybody hazard a guess why that happened? 2013. Go on, give me some answer. Otherwise, I'll also sleep like you guys.
Communication problem.
Yes, essentially all violence happens out of communication problems, even if it is a marriage. But this was specifically because of one event in the state. Sorry, sir? No, all villages and rural areas, everywhere this was happening. They haven't heard of consumer redressal. Sorry? Sorry? Dr. Rajkumar? No, not Dr. Rajkumar. The poor soul has nothing to do with it. They started an accelerated taxi service that we all call in our country called 108 system. What did 108 system do? People who would have died at their home, workplaces, fields, factories, who were desperately unwell, were suddenly picked up by these ambulances and taken into hospitals, rural hospitals nearby, which didn't have the capability to deal with dying patients. They are good with elective cases, outpatient services, but not when somebody is coming in heart attack with no blood pressure, they didn't know what to do. Somebody bitten by a snake, gasping for their last breath, they didn't know what to do. So when these incidents were reported, Swami Vivekananda Youth Movement did a survey in the districts of Mysuru and nearby districts. They asked all the rural doctors and nurses, what's going on? Answer came, too many are coming, we don't know what to do. Suddenly this stupid ambulance system, they're bringing in patients, we don't know what to do. So what do you need is the next question. Can you please teach us these groups of emergency, which is respiratory, cardiac, obstetric, neonatal and pediatrics, trauma and burns, toxicology and bite, snake, dog, whatever it is. We don't know what to do. Please help us. Out of that was born JeevaRaksha. What's the solution? The solution is you need to go to a city, stay there for weeks, pay American Heart Association or American College of Surgeons huge amounts of money to learn. Trauma, you got one course. Neonatology, you got another course. Cardiac, you got another course. Multiple courses. At that time when they calculated, it was more than 1,50,000 rupees only for the fees of these training programs. Can our rural doctors and nurses afford it? No chance. And on top of that was traveling, staying, being away from family, work, etc. So we needed a solution. And God sent a technical supporting team from University of Utah. 2013, what was happening in India? Any idea? We did really well. We came number 2 in a particular international event. I'm asking too many questions, no? It was a Commonwealth Games hosted in Delhi. Okay, so see, one thing we've all realized, especially if you've been to overseas, is Indian lives don't have any value, you know. Millions die on a daily basis. Today it's a news report if you're a celebrity, tomorrow you're forgotten. Well, in their countries, if their people die, life has got a lot more value. They spend awful amount of money, time, training to save every single possible life. Here it is cheap. One of the reasons I'm back here is because of that. Because I don't think we are that cheap. We've got the best doctors in the world. We've got the best hospitals in our country. We've got a tremendously wonderful public health system. But unfortunately, the lives don't carry the value they should. So how can you prevent unnecessary deaths from emergency? When their people are coming to our country to attend any function, there are little small prints. They just don't send their athletes or their delegations to India or any other country for that matter without certain things being fulfilled. Do you have an ambulance system? We do. Do you have trained paramedics in those ambulance systems? We don't. Okay, let me send you Professor Peter Tylak from University of Utah to train your paramedics. So Professor Peter Tylak was in India, about 6 months before that, to train the paramedics in Delhi so that their people could be looked after well according to international standards. Okay, because coming back to international standards, we said 1 in 10,000 or less survive from a cardiac arrest in our country. What's the survival in Europe? If I give you 10,000 pre-hospital cardiac arrests, what's the survival in Europe? Shout out. 500. More than that? More than 500? Sorry? 40, yes, up to 40. So 1,500 to 4,000 people live, not just live, and go home with good cerebral activity if the pre-hospital cardiac arrest is happening in Europe. What about US? Similar numbers, 1,500 to 4,000. I'm making it in thousands because to compare our number, 1 in 10,000, I need that bigger scale. In a city called Seattle, heard of Seattle? What's the survival? Anybody knows? Nearly. So it is 6,800. Good. Who is this? I like you. Well done. 6,800. 68%. Why? What has Seattle got that New York or Washington or Berlin doesn't have? Crane. Training. Yes, skills training. Very good. Anything else? Emergency response system is more or less the same, but something called defibrillators, the machines which give electricity to the heart. You know, many of you are A+, accredited for NAC or NABH, etc. These machines you open from the shelf once in a year to show the inspectors that we got everything. Those things are found in every block in the city of Seattle, and people are trained how to use them. People, not healthcare professionals. Because at the end of the day, if an emergency happens, more than 90% first responders are going to be non-healthcare professionals. So we've got a responsibility, don't we? Something simple can be done to make a huge difference, huge impact in our nation. We're all standing up ramrod straight, shouting Jaya Jaya Hey. It should mean something. It should mean doing something to create a positive change within our short lifespan so that the next generations at least don't suffer from the ignominious death rate from significant emergencies. Agree? Thank you so much. Shall I start with the slides? Thank you. So, these three came together, created a project called JeevaRaksha in 2013. First instructor training program happened in 2014. Since then, Rajiv Gandhi University spent about 84 lakhs in creating instructors over a period of 5 years. There's something called NELS. Anybody heard of NELS? National Emergency Life Support. Very similar program. Huge amounts of money has been pumped in, but it hasn't kicked in yet. Do you know what's the biggest difference between NELS and this program? Handbooks are more or less the same. Curriculum is more or less the same. If you have a bunch of experts anywhere in India sitting together, looking at these conditions and how to manage it, we'll all come with the same kind of answer. Only difference is they insisted on clinicians training the candidates. So when I visited Delhi in 2019 to talk to the then health secretary, we were told that 16 instructors were trained after spending 400 crores over a period of 5 years, and 16 providers had come out with NELS certificate. In the meantime, we had 700 plus instructors and thousands of providers after spending 84 lakhs, which was spent by Rajiv Gandhi University of Health Sciences. Only difference is we went to the best teachers in medical colleges. Those who are passionate from year one, who has taught us the direction of which way a nerve goes, what is under this canal, all these things. So we use pre-paraclinical teachers as well as clinical teachers in becoming instructors. And we embedded into the medical college system. In 2019, Rajiv Gandhi University of Health Sciences made it mandatory for affiliated institution interns, started with medical, to have this program before they get their degree certificate. That made the biggest difference. Okay? So this is a real story. Bangalore, 8-year-old son of a surgeon, COVID times, peak of pandemic, really bad shortness of breath for 5 days, getting more and more unwell, became unconscious. Surgeon took him and ran into the emergency room of his own medical college hospital. We were all doing COVID shifts, remember? It didn't matter what specialty you were. So during that time, unfortunately, it was a plastic surgeon who didn't have any training, who didn't know what to do, and the child died. One of our own. Not talking about any number who died otherwise. Okay? This happened. Why? Because we believe that the more and more we learn about less and less, super specialization, isn't it? The less and less we can do for the critically unwell. Okay? So how do you change that? As I said, most emergencies seen in the low resource setting with the least trained doctors. There's a huge demand for trained professionals in our country. But unfortunately, the MD-DMB system of emergency medicine is not fast enough. You have to address the gap by training the doctors early as well as those who are already in the PHC and other setup. What is the key of emergency medicine? They come in all different shapes and forms. 90% will be stable. The 10% or less who are unstable, you need to recognize them early. You have to start stabilizing them as you start recognizing. And don't keep them for too long. As soon as they're stable, shift them across to specialty, theatre, CT scanner, whatever is right, or to the next hospital if you're in a rural hospital. So early recognition, prompt resuscitation, and a safe referral and a safe transfer is very, very important. And that's what we teach them. So I've told you all this. What is different about this program is it's world's first comprehensive. It is not one particular specialty based. You've got 7 different groups, multiple emergencies, and it is accredited by a university. All the other courses you have are accredited by professional organizations. Okay? You might have gathered or understood the vision by now. We are here only to save lives. And how can you save lives? By providing a quality emergency care. And mission is a bigger explanation of how we are going to get there. I'm talking about number 1. We are also doing research and development as well as rehabilitation and relief. So disaster management, pandemic management, all these things are also happening. So currently we got the top 3 courses running seamlessly at the moment. So you got the doctor's training program, which is a comprehensive emergency care life support, 4-day program for the interns or final year medical students. Best done just before they start internship. Because the commonest feedback we get is, we wish we had this program before we started internship. Because a lot of skills, we didn't use it for the last 8 months. Maybe we killed a few patients too. The nursing program is not a lighter version of the doctor's program. That's what we normally do. ATLS, nurses can come as an observer. ACLS, they start as an observer. No, this is written by Indian nurses from primary, tertiary and medical college level, as well as international nurses. We got transport, specialist transport nurses to come in and write a module which is the need of the hour for our nursing faculty, nursing specialty. Because if you don't improve nursing, you can train any number of doctors you want. Nothing will change in the wards or on the ground. The basic emergency care and life support program is not just BLS. What people think is, when you see a B and an L and an S, CPR and choking. It's got 10 common emergencies that we come across in our country. We are the world leaders in deaths because of accidents, deaths because of lifestyle diseases. So heart attack, stroke, trauma, burns, snake bites, seizures, hypoglycemia, all these things are covered in that one-day program. It can be done by anyone from 8th standard education to an allied health or an Ayush or a pharmacy, physiotherapy kind of person, because it doesn't matter what your title is. When you come across an emergency, you are the god for those patients. There's nobody else around. If you do something then and there, you might save a life, stabilize the patient, and then be able to refer them somewhere. If you don't do anything, it will be too late. Then this year, these 3 courses got approved by the university. One is trauma care and life support. It's a trauma team training. We are not trying to replicate anything which is already there in the world. From nurse to healthcare assistant to OT technician to ICU nurse to all the different doctors who get involved in trauma, we need to train them as a team. What are your roles? What are you supposed to do? Simulation, moulage, scenarios play a big part in it. That's how you embed the skills. Obstetric emergencies, again, from an obstetric perspective, emergency room, labor room, obstetric theatre, emergencies, how are you going to manage? Because when somebody is critically unwell, whether it is obstetrics, trauma or other hospital emergencies, it is the ABCDE protocol. What is ABCDE? What is ABCDE? Not apple and no. Okay, good. So airway, breathing, circulation, disability, exposure, and also hemorrhage control. C for cardiac compression initially in cardiac arrest. Huge numbers of research proven life-saving protocols available out there. So people are trained in those protocols. We are not training them how to conduct a complicated obstetric surgery. Okay? So I've covered that. You know what they are. It is a single course. It's a one course to hit everything. And currently dental specialties as well as Ayush specialties are asking for a specialist course for them. We are working with them. It might also come out shortly. What is this? Not moving? Can you get me the next slide? Yeah. So from a teaching perspective, Dr. Praveen, are you here somewhere? Dr. Praveen is from Tamil Nadu Apex Skills Development Council. He had come in as a Bakra or a volunteer to come and do an instructor training program with us just a month ago. 10 days you spent in Chitradurga, and he will tell you he couldn't relax or rest over the 10 days. It's a boot camp style training. Protocol step by step by step, and you have to understand and make it muscle memory. If I wake him up from the middle of the night and ask him what are you going to do in a neonatal resuscitation protocol, he will start chanting 1 and 2 and they're basically made to repeat and learn the skills. And we don't pass anybody. They have to really demonstrate the skills to pass the exams. So it is intense and it is heavily practical based. You have got 70% skills training and only 30% theory. The technical skills we teach. Most courses teach them, but what we don't emphasize on is the soft skills. If a road traffic collision happens in the highway between Chennai and Puducherry, looking after the neck of the patient is important, tying off a bleeding is important, contacting ambulance is important, but you know what is the most important? Not to become the next victim of a road traffic collision. Scene safety, being a leader, good communication skills, managing the people around to make sure that you can do the rest to the patient. Otherwise, you are the next victim. Any number of cases are reported where an auto rickshaw driver or a two-wheeler or a car will step out to help and get mowed down by the next vehicle which is coming through. So those elements also we teach. So this is not just about training in skills, it is about communication, it's about leadership, it's about coordination, it's about delegation, it's about critical thinking, problem solving. all the C's and the P's and other things you talk about in an MU environment. Okay? Sorry, assessments. You got the formative and the summative. You got the 360-degree feedbacks and the mentoring which starts from day 0 in the program for the formative assessment. Summative, you got high order MCQs, you got OSCE scenario station. So it is very well designed to comprehensively collect information from them throughout the program, not just by one test. And we believe in retesting equals relearning. Even if it is a chairman's daughter or son, retesting is relearning. Nobody just goes through, because tomorrow they will go and do something to a patient and learn on the patient. We don't want that. They need to have the skills. Agree? Not agree? Sleep? Thank you. So, what's the journey so far? Quick summary. Started in 2013, first ECLS course in 2014. Trust was registered in 2019. Why? Too much of demand from outside of Karnataka. So we had to be fast enough to respond outside of the government hierarchy. So a trust was registered, and the one Bakra who was doing this 24/7 pro bono with some qualification emergency medicine was made the CEO. Sorry, you have to listen to me. And it was made mandatory across Rajiv Gandhi University. And these two programs, BCLS and ENLS, happened in 2019-2020, and the other three have been approved in 2022. Currently, we got 839 instructors. So this is because if you don't teach at least 2 courses every year, you don't become an active instructor. You can't just become an instructor and you're an instructor for lifetime. So you have to be teaching at least 8 days in a year to keep your instructor status active. So currently active instructors 839. The emergency nursing and life support is currently in the instructor formation period. So COVID kind of slowed us down a bit, so that is why the numbers are low. BCLS 296, we are sort of focusing on community training as well. And ECLS and ENLS guys can teach BCLS. ECLS guys can teach ENLS. Okay? And providers, those are the numbers. 5,574 for the ECLS, ENLS 433 and BCLS 32908. From this year, we're going to have a much bigger jump in numbers because COVID is over. No more excuses. If you don't have the course, you don't have the certificate. We can enforce it a bit better. So we have signed MOUs with 6 plus 1 was the number. Okay, 6 we had signed. Today we exchanged an MOU with your prestigious organization as well. So it is 7 at the moment. We've also covered Morocco and Uzbekistan other than India. And last month about 20 of us were in Bhutan training their nurses, doctors, paramedics. And they want us to go back and train them in disaster management as well. So I'll sort of leave you with one comment in that perspective. This was funded by the Japanese Investment Corporation arm. And Yoda-san, who's in charge of Bhutan and all the funding, they're very, very strict. You have to give every little receipt, you have to give the original. He said, you guys are very punctual and committed and passionate. If you were Japanese, I wouldn't have been surprised. I took it as a compliment. So that is how we've been sort of militant even in there. So there were many, many more Praveens and others in Bhutan who were put through the mill. So just a set of feedbacks from our programs. Right, thank you. So, by this time you'll be wondering, how do we do it? What does it cost? What amount of headache does it involve? Is there any politics? What is the paperwork? Etc., etc. I would like to invite Dr. Lulu Sherif to come and tell you how to take the program and onboard it and make a difference to your institution and the students and the faculty. Over to you, sir. Thank you. We'll take questions at the end together. Thank you.
This is Dr. Lulu Sherif Mahmood. She is a professor in anesthesiology, head of the healthcare simulation and education, Training Center Coordinator for AHA and JeevaRaksha courses, Quality Manager for Hospital Training of Father Muller Medical College, Mangalore. She has been a first applicant for the India to certified CHSE certified courses. She's a Master in Health Simulations and Patient Safety from National University of Ireland. She also has been a team STEPS Masters Trainer in AHRQ and USA. She has been reviewed for IMSH for the last 3 years. She has also been a chairman for the associate editor for reviewer for the IJOHSS journals and a chairman for curriculum committee for simulation studies, Kerala University for Health Sciences, and has been an executive member of Indian Society of Healthcare Science. Over to you, madam.
Thank you so much, sir, for the kind introduction. After that dynamic lecture and interaction from Ram, I hope I don't put you back to sleep. Yeah. So I'll just take 10 minutes, even though I have 28 minutes, because I want to give the rest of the time for you all to interact. So what I'm going to do right now is I'm going to share our experiences of how we run the show and why we are so passionate about the JeevaRaksha concept. So as Ram mentioned, 2019, we get a notice from the university that it's mandatory, and the university and the state government was funding 10 instructors from every medical college under Rajiv Gandhi to become instructors so that we can carry forth and train our students. So it was kind of something comes from the university with that emblem and that seal, so our college has no other choice but to send us and fund the whole thing. So 10 of us went to Davangere, that time it was in Davangere. So they had started doing the program before us. A little skeptical about how it was delivered because it was still a little bit raw, but we were very, very passionate about the cause. So that was very contagious for all 10 of us. And the best thing was, because I was the skill lab in charge, so I was leading the team. But at the same time, this course was supposed to be delivered to the medical students. At that time, ENLS was not yet out. So to the medical interns at an MBBS level, to manage an emergency in a rural health center, which is a low resource center. And what was the objective? They have to recognize, stabilize, and they have to transfer, safely transfer to the nearest tertiary center. This is all we expected them to do. We didn't want them to have some differential diagnosis or, waste time. So for that, getting clinicians on board is difficult. Even if you train them, we were not quite sure about the commitment level from their side. And we didn't want them to teach, we wanted them to teach CPR. We didn't want them to teach cardiopulmonary bypass, if you understand what I'm trying to say. So we targeted phase 1 and phase 2 medical educators from our college who are very passionate, most of them from the medical education unit, so it becomes very, the teaching and the dedication, what we find in the MEU members, the humility and the modesty, I shouldn't be saying that, but that passion and dedication we could rely on. But they were also like, ma'am, I'm from anatomy, how can I teach somebody how to teach emergency? I've forgotten my MBBS, and during our MBBS and even now, emergency is not a part of the curriculum. I mean, it's not consolidated. We do learn here and there bits, but it's not consolidated. So we had a group from pathology, biochemistry, community medicine, pharmacology, and I went along with them. When we went there, like I said, we were very passionate about it. So how was our journey? This is our center, where just a glimpse of how we set up almost every 3 months to do the course. We were the first regional training center, certified regional training center in Karnataka under RGUHS for ECLS and ENLS courses. So starting from the vision, we were very passionate about the course, came back and told the management, every medical college management looks at 2 things. Is it mandatory by a regulatory body? Yes, they will do it. Is there any return on investment? If it's a private college, is it a status issue? Yes, they will do it. So banked upon that, because it was mandatory, but the feeling of giving back to society was very innate in all of us who went. It is high time we give back to our community. And this is one such course which just connected to us to give back at one time or the other as a healthcare provider. We teach somebody, that somebody saves somebody's life tomorrow. Yes, we have given back. So it was a community initiative which we were passionate. Vision, it was stakeholder because we were under Rajiv Gandhi University. They had no choice and we went on with it. So that was our main vision which helped us. And every time we recruit, one or two talks from Ram or Vijay or whoever is coming from JeevaRaksha, they just connect with us with all the death rates and you just get caught on like, oh my God, this is a situation. What if somebody is a relative? We need to give back. So it just catches on with you. Next. Convincing the leadership was okay, but what about the investment? And at the same time, you needed a JeevaRaksha team. And it should be led every time, So step back as a clinician, give the lead to a pre or para teacher. So our JeevaRaksha courses earlier was headed by Dr. Sumant, who was a pathology professor. When he left, it is now headed by Dr. Shailaja Katti, who's a biochemistry associate professor. So she's heading our JeevaRaksha courses. Very well, she's heading it. And she's also one of the senior instructors. So leadership is very important when you form your team. And convincing your leadership to recruit more people. That is also very important. So that is where we clicked when we had a good leadership and stakeholder in convincing the stakeholder. Teamwork. I won't settle it and say it's an easy job. It's a resource-intensive course. I won't hide it. You need to spend 4 days away from your department work, and you are engaged in multiple stations. You are paid salary to teach biochemistry, and you have to learn cardiac emergency, pediatric emergency, obstetric emergency, and you have to teach them. So the teaching part and the learning part is now almost standardized because there are a lot of inputs from all other colleges. The manual is standardized, there are faculty guides, so it becomes okay. We are monitored and we are observers. We do go as observers, and observers do come during the course. That is to maintain quality assurance by JeevaRaksha. So the teamwork is very important. We have a JeevaRaksha team. It started with 10, 12 members. Now we have recently recruited and we are around 35 instructors, more from the phase 1 and phase 2. And there's a lot of good teamwork happening. And you won't believe it, when the phase 1 and phase 2 teachers come and tell us that they were empowered for finally feeling like we are doing something on the clinical side, and they actually take it back to their department studies when they touched on their topic. So there was a lot of empowerment from the teachers and there was a lot of dedication. So teamwork automatically builds up when you attend or deliver one or two of these courses. We do have clinicians who are content experts. So we have one or two pediatricians, we have surgeons, we have from the obstetric side. So we do have 2 or 3 clinicians who are content expert and are part of the JeevaRaksha team. Very, very important is technical support. You need a technician, or at least somebody who's managing your skill lab, because there's a lot of preparatory work to keep the skill stations ready. On the exam day, you have around 16 to 18 skill station who runs like OSCE, and you have to keep it ready. And every day, so we are a dry lab, we don't use the wet lab, but some colleges who are not so privileged like us have to use their cadaver lab for all the wet surgical procedures. So technical support is very important. Infrastructure, since NMC has made it mandatory that skill labs should be there, you don't have an extra setup to start a JeevaRaksha. As per JeevaRaksha, for all the equipments required, around 20-25 lakhs are required. But whatever is the NMC skill trainer, barring a few, maybe like some breast trainer or Foley's, a few of the things are incorporated in JeevaRaksha. And if you buy the JeevaRaksha equipment, whatever they have listed out, the training, it depends on the number of students, 100 students, 150, 200, 250. So infrastructure is also very key, and investment is required over here. So how did we run the show? We have skill lab fees. And JeevaRaksha has also told that you can take fees. I mean, Rajiv Gandhi has kept a cap for us in Rajiv Gandhi. We cannot charge more than an amount. It was 5,000 for the last 4 years. Recently, because of the inflation and because some colleges couldn't meet the ends, they've capped it up to 10,000. So with that 10,000, you run the show, you feed the students, and you pay your instructors the incentive mentioned by JeevaRaksha. So lead gets so much, level 1 instructor, level 2. We have customized a little, and whether lead or anybody else, we give the same amount of 1,500 or 2,000 per day for the course, whichever instructor is coming. So because of the skill lab fees otherwise also taken by the university, we are able to manage. JeevaRaksha is not a profitable course. It's a no gain, no loss course. But you can make the profit out. If you're outside Rajiv Gandhi University, you can take the fees from the students, but 30% you have to give it to Rajiv Gandhi and JeevaRaksha. So that's about the infrastructure. Feedback Ram has already mentioned, though we've not yet documented, they're collecting data. Many students message, WhatsApp us and tell, ma'am, because of this, one patient is saved, or they're able to get back the patient to the tertiary center, and we are seeing the impact of these courses. So that is when it gives us the motto and, the passion to continue doing it. So the feedback of the JeevaRaksha courses is excellent, and I'm sure you'll be convinced if you're starting it. Again, networking, that's why I put up this slide. Networking in JeevaRaksha, we offer a few inputs, suggestions. We'll take a lot from the other institutes, and there is a JeevaRaksha community right now in Karnataka, where a lot of things have changed and a lot of things are dynamic, and we are able to maintain quality assurance with that. During the COVID time, we've customized a lot of hybrid courses and what to do, and they're coming up with the LMS also. So that's all from my side on how we have implemented it at Father Muller's, and the next few minutes is for interaction on any doubts, any questions on how you should do it. Me and Ram together will answer your questions. That's all. Thank you so much.
Dr. Ram and Dr. Lulu.
Thank you.
Really, I am impressed what work you are doing. It's not just as a medical faculty you are doing just training, but your passion is actually appearing here in your work. The amount of work you have done, you have trained almost 33,000 BHCLS providers and ECLS about 5,500. It's not a less number, and you have not limited your field to only clinicians. That gives more confidence to preclinical and paraclinical people. So that is also one important thing. Another thing, community. You are involving community also. So you are training community also for this. So this is really tremendous
Thank you.
Work and very impressive work you are doing in this field. Only thing I could not understand why ENLS takers are very less.
Ma'am, the first ENLS course was done in Father Muller's in 2019. The issue is we don't have that much of instructor pool right now. So we are regularly doing our ENLS courses with our nursing interns. But in the rest of the state, there is a lack of instructor pool because that COVID, when we introduced ENLS, the COVID was a kind of a huge barrier for us to get the ENLS instructors on board. One reason is because most of our nurses, majority are from my gender, and whenever we do TOTs, it is very difficult for them to leave their domestic household and then come for 3, 4, 5 days for a TOT course. So that was one big barrier for us. So we're trying to increase the number of TOTs, but again, we wanted senior instructors. I think Ram can add on about the ENLS. And it is mandatory for the nursing interns also. Again, the fees we will have to reconsider, because sometimes it's, again, pinching on. Most of our nursing students are coming with loan, educational loan. So that side also there is a little bit of challenge for us on the ENLS side.
Madam, we started the TOT program in 2020, and the training of trainer program, we don't believe in hybrid or LMS or online. It has to be hands-on, it has to be face-to-face. So when COVID was at its peak, we couldn't do that face-to-face program. So that kind of reduced the velocity and the momentum of the program. Now we are back on starting pretty fast. So in a year or two, we'll be hitting our targets that we are after.
Actually, what I think that university now they have made ACLS and BLS training compulsory for interns. Why we should not have 15 days training like this for our all interns? So that that will be automatically, that will be in the stream. And another advantage, our students when they go to community, when they work in rural area, they will feel more confident in handling any type of emergencies.
What the model we are following now is all interns and PGs, they get the orientation induction when they come. Other than the academic and the research orientation, we have hospital orientation, as well as, like you mentioned, ma'am, even our institute makes BLS and ACLS of the AHA mandatory. But along with that, we have JeevaRaksha ECLS also mandatory. So we try to finish. Scheduling sometimes is a problem, because today results will come and tomorrow they have to join. At a batch, we can take only 25 or 30, not more than that. So we select the 25, 30 who are going to the community first. So before they go to their community medicine posting, we finish training them in ECLS. And after that, we give a gap and take the next 25. Because it's not feasible to run the whole show with all 154-day course, getting the instructors. Every HOD will call me and they curse me and say, how many times you tell my instructors to live in the skill lab? This is what they say. So because we have 35 instructors now, it still becomes easy to relieve them from so the huge conflict here comes when you're relieving instructors from their parent department and you're scheduling these courses.
So instructors training for the medical courses is 10 days, sir. No, 5 days is a step one, where they have to pass with 90% mark in theory and 80% marks in practical for the base course, whatever they're training, part one. Another 5 days, yes, which includes a day zero. So they are taught how to set up a course, right from ensuring that the toilets are clean and the directions are posted on the walls. We take into that level of details of organizing a program. Because many times you find that the senior medical people are not used to organizing to that level.
Out of 859, how many are from preclinical side?
About 60% or more, easily.
So, Yaran and Lulu.
Yeah, simply go ahead. Go ahead.
This any cap in the number of participants you take for a course? Or?
You know, the cap is 30 maximum, and there is a ratio also, 1:5 instructor to candidate ratio for the ECLS program. For the other programs, it's 1:8. So we don't believe in standing and delivering to 500 candidates. This is how you save a life. They have to be taken through the practical steps. Yes. So there is a cap in the ratio as well.
If I may add here, Ram, sir, because we have a lot of medical educators also within our JeevaRaksha team, so we kind of improvise it a little at one station. We don't have more than 4 or 5. So if it's a neonatal resuscitation station, we keep more stations. It depends on your resources. So if we keep 2 NRPs, we can have only 3 at a station. So it's kind of the quality increases with 1 instructor and 3 students, because this is a hands-on skill station, and we want everyone to touch the baby. We want everyone to wrap the baby, because the neonatal and maternal mortality is quite high in Karnataka. So these are the 2 stations where we are very particular about PPH, eclampsia, trauma, and NRP.
And you told?
Health screening for the instructors, madam. Any health screening for the instructors?
Right now, in our institute, annual health screening is there as part of NABH accreditation. We have to screen our teachers as well as all the doctors and employees. Okay. So that is there. As part of JeevaRaksha, it is not there as a health screening.
Any age limit?
No, ma'am. Our oldest instructor is 74 years of age. His name is Professor Narayana Holla. He is an emeritus professor of community medicine, and he came all the way to Bhutan and trained in high altitude for 15 days. He did well.
Any challenges you faced during training the instructors from the non-clinical side to the clinical side? In terms of commitment?
If I may, ma'am, we have a lot of motivation and enthusiasm from phase 1 and phase 2 instructors. Clinical, those who are passionate right now because of the good word, a lot of clinicians are passionate and they're coming. Earlier there was a little resistance when the college thrusts, okay, it's an emergency course, so anesthetists go, critical care go. So there's a lot of hierarchy. What are you teaching? This is not what our guidelines are. This is not how you'll manage, without knowing what things are there in the rural health setup. So we might hardly have one diazepam there to stop your seizure. And the discussion in a TOT is a little delicate for us. So we kind of, at the senior instructor level, we know our participants. We know who are, I won't say problem creators, but we know who will give us issues at TOTs. And that is why TOT is always face to face. But we are able to mellow them down after 2 monitoring when they understand the intent that this is purely for a low resource setting. You may hardly have a working laryngoscope in any PHC, ma'am. That is our intent.
Ideally, you are looking for how many instructors in a medical college?
Depends on your medical student numbers, sir. So if you've got 100 to 150, ideally 30, I would say.
Yeah, we
30.
have around 30 would be okay for 150 because we are managing well. We have 35 now, around 35 instructors. That is actually a luxury considering our setup, but we need, sir, because it's not easy to complete courses for 150 for 4 days, relieving them, and it's a little tiring because you have many stations, especially on the exam days are quite tiring. It's like a boot camp, military boot camp setting. Dinkar sir wanted to, yes sir.
Yeah, so one of the problems we face whenever we are doing any skill-based teaching is the deterioration of skills over time.
Yes.
And normally there's a recommendation that, for example, in ACLS and BLS and all that, you do it once every 2 years. Do you have any such plans or program for yourself that you repeat it over, or you say that you have to be recertified after a particular period of time?
Yes,
Or
sir.
is it just one shot?
No, sir. This certification is actually 5 years. It's valid for 5 years. So right now, if you finished your internship from a college under RGUHS and you've joined as postgraduate next year, you don't have to do it now that they've made it mandatory for PGs. And regarding attrition of skills, yes, sir. Even though AHA is 2 years, because we have our own students who's completed ACLS, 3 months later, you're calling them for code blue and they've even forgotten on, what their skills are, unless they belong to the critical care. So attrition of skills definitely is there. We are in the talks of trying to do a reinforcement, but the only problem is again logistics, sir. By the time we finish 150, 200 in a year in 4 batches, to get them again is difficult. So what we have told us interns are, Skill Lab is open. When you find that you need to reinforce, please come back and let us know because we have a package for slow learners and remediation. So we don't pass them at first shot if they are slow learners. So for those remedials, and on the public domain, yes, for theory, videos are there, manuals are there, they can approach us. We have a networking WhatsApp group for the students to contact us. Hands-on skill is still a challenge for us for deliberate practice, sir. Yes, sir.
Okay, any questions? Otherwise, you have finished in well in time, both of the speakers. Dean sir. Dean sir wants to ask. Please, sir.
Sir. Very nice session with you, sir. And technology and infrastructure plays a main role in emergency medicine. So my doubt is, you have explained that abroad they are using defibrillators in common places, and I have seen the videos also. There are instructions, manuals for using defibrillators. So in JeevaRaksha, what sort of infrastructure and technology you are going to introduce in public communities, and where you are going to plan?
So we are teaching them AED. We are not teaching them defibrillators, manual defibrillators. And the government of India has now made it mandatory, and it will come very soon. Every public place should have an AED, and every lay person should be able to know how to use an AED. So JeevaRaksha is still teaching them AED. the automated external defibs.
So most airports have them. Most public meetings with more than 1,000 people aggregating, you're supposed to have them. They don't keep it. And talking about technology, all our course videos, like the how to perform a certain skill or run a certain scenario, all of them are currently available for the public through a YouTube channel called JeevaRaksha Videos. You can check it out. And on the other hand, there are two apps which we are coming out with. One is a provider app. So most of the time we teach thousands of people, but if they're not useful for the community in the pre-hospital environment, then what's the point? So this app is like a Ola or a Uber based app where somebody who's downloaded it, everything is free of charge, is in trouble or somebody is in trouble next to them, they click on it saying, I'm having an emergency, or there are 6 pictures, broken bone, breathing difficulty, pregnant lady, child in distress, overdose. So there are pictorial graphic images for that. You click on it, we get the information of your GPS location, where you are, and 15 minutes traveling distance. The providers who have signed up to be available for this will get a ping. Whoever picks on it first, like an Uber or Ola driver, will get the case and their phone number and where they're located. You will get a sat-nav direction to them. The patient or the victim or the carer will get an information about how many minutes they are away, and you can make a video call through the app. So simple example, seizure, hypoglycemia. You can easily correct it without even being there with the patient. Or a fall from height, please look after the neck. Don't pick and throw into the back of an auto rickshaw. Simple instructions can save lives and necks and whatever else. So that is one app. The other is a learning management system, which we are trialing this month, expecting to be coming out in January, which will enable us to scale much quicker because all the theory will be carried on that. There will be quizzes, there will be all sorts of learning modalities in it, and the candidates will have 5 years access into the LMS moving forward from whenever they complete the course, so they can revise and refresh through, and any update that comes also will be updated through the app.
The apps will not replace the training. No?
Definitely not, sir. No, definitely not. No.
So we'd like to thank iCON and what's
Final, sir.
Last question, Deed sir.
Okay, so I will divide the last question into part 1, part 2 then. One thing is, I must share the experience. I had an opportunity to undergo BLS, ACLS training in the city of Chicago way back in 1999-2000. As a part of that program, we were taken the ambulance ride in the city. That time, about 24 years back, the reaching time was 6 minutes. And 3 components. One is the firefighter, another one is the ACLS provider and the police. They used to have a joint station. Okay, and anything that kind of a thing happens, it comes there and it goes to various hospitals. This information I wanted to share. What I primarily wanted to share the information was the relieving the faculty members to undergo this training to work as instructors, etc., has been a problem. Not only for this BL life-saving activities, even for the medical education unit, the research, because the faculty is expected to spend the time for all that, and the particular department doesn't give any concessions. So we made one rule in Kolar. Whoever is spending time, weekly, he spends about 3 hours, 6 hours, he is interested in medical education, let him go. His share of burden of the class will have to be mandatorily shared by the other staff members. You make it a rule. So I am going and spending, my passion is medical education, my class on that particular day will have to be mandatory. It is a HOD's headache. Because I go and request you, you will say no, why should I? That was the one which worked.
The only issue with us is our instructors finish their work and we relieve them on non-OPD day, non-OT day. So it is still challenging, but we are doing it because we have a...
The heartburn is, during the same time, if you are earning something, it will be heartburn for the others.
Yes.
So best thing is, if it comes from the top,
yes,
that will be the best one. And the part 2 is this, after the installation of these AEDs in market, bus stand, railway station, beach, etc., these developed countries included AED as a BLS procedure,
Yes.
which is a long way to go in India. Okay, only after that we can think that it is a BLS procedure.
And another thing we do, sir, is we teach in the local language. So there is currently Kannada, Hindi and English versions of the BCLS program. So I need help in translating it into French and Tamil, please. Thank you.
Thank you so much.
Both the speakers finished in well time, and also there was a good discussion by the participants here, delegates. Now I conclude this session.
Thank you, Dr. Ram Nair and Dr. Lulu Sherif. Now I request the chairpersons of the session, Professor Pushpa Kotu, to present the memento to the resource person, Dr. Ram. Now I request the chairperson, Professor Kalsat, to present the memento to the resource person, Dr. Lulu Sherif Mahmood. Thank you. Now I invite Dr. Ambujam, Dean, Vinayaka Mission Medical College, Karaikal, to present the mementos to the chairpersons of this scientific session. To Professor Pushpa Kotur and Professor Kalsat, sir. Thank you, ma'am. Thank you, Professor Pushpa Kotur and Professor Kalsat, for chairing this session. Now we'll move on to the next scientific session. I'd like to invite Dr. Deepthi Shastri, Deputy Dean, Professor of Anatomy, Vinayaka Missions Kripananda Warrior Medical College and Hospitals, Salem, and Dr. Vijisha Falgunan, MU Coordinator, Professor and HOD Anatomy, Sri Lakshminarayana Medical College, to chair this session. And we have Dr. Nachiket Shankar, Professor of Anatomy,